started. So welcome everyone to PEARS. We are excited today. This is the Pediatric Education Research Series that we have created for the research coordinators and nurses. And we've also invited some investigators to attend if they want to. So we're excited today to be talking about biostatistics support for investigators. And we have two great speakers today. We have Scott Gillespie, who serves as the Interim Director for the Biostatistics core, the Pediatric core. And he's worked at the Department of PEDS for almost 9 years and has collaborated on over 500 clinical research studies and resulting in 80 peer-reviewed publications, which is incredible. And I know I collect all the publications and I see his name very often. He's contributed to numerous internally and externally awarded grants and hundreds of accepted conference abstracts. Scott works largely in critical care medicine, infectious disease, the Aflac Center, and the Marcus Center, Marcus Autism Center. But he aims to assist anyone doing pediatric research. He holds 2 master's degrees, one in biostats from Middle Tennessee State University, and a second public health bioinformatics from the Rollins School of Public Health. Our second speaker today will be Janet Figueroa. She has an MPH in Epi from the Rollins School of Public Health, and she previously worked as a data analyst for the Strong for Life program at Children's. And she currently serves as a senior biostatistician in the Pediatric Biostats core. She joined in 2016. She has provided study design, statistical and data management expertise to multiple pediatric divisions throughout Emory and Children's, including critical care medicine, Emory emergency medicine, neonatology, and most recently the RADx initiative that aims to improve COVID-19 diagnostic testing. So I'm going to hand it over now to Scott. And what we want to do is, if you want to ask questions during the presentation, please enter them into the chat and I will ask Scott or Janet those questions as we go. This should be treated as a very informal situation where you can interrupt whenever you have a question. And if you do want to wait to the end and ask a question, we'll also have a question and answer period at the end. All right, Scott, you want to go ahead?
Yes, thanks, Barbara, and thanks everybody for having me today, having Janet and myself today. We're excited to show you a little bit about us and what we can maybe do for your research, or hopefully do for your research. So our presentation today is titled Tips for Collaborating with the Statistician. And we wanted to kind of tell you a little bit about who we are, how you can reach us, and the services we can provide for your research. So let me see if I can, there we go. So what is a collaborative biostatistician? So collaborative biostatistics is the creative application of applied statistics and their tools to areas of biology and medicine. That's like a formal textbook definition of what a collaborative biostatistician is. But really, I think there's 2 broad areas where we can really add value to your research enterprise. The first is really into study design. So people, and I'll get to this more in the presentation as we go, often come to us fairly late in their research processes. And I think that can be a hindrance to them because we really have experience and expertise in all facets of the research process. And study design is critical because so much of what you can do and the conclusions you can make in your research stem or start with the study design. And when I say study design, it can be lots of things. It can be a hypothesis refinement. It can be conceptualization of the complex relationships between your variables. It could be sample size. It can be, is it prospective? Is it retrospective? Is it cross-sectional, longitudinal? How can we best answer your question given the data that you can reasonably collect? So we can hopefully inform you of that early on in your studies. And that's why we hope that you come to us as soon as possible. The second thing that biostatisticians do to add value to your research is in data analysis. And this is what people typically think of when they think of a biostatistician, right? You've got your data, you hand it over to us, and then we work up the results. We then hand it back to you. We interpret those results with you, and then we write them up. And that's a very critical part, and it's a very important part. I do hope that folks don't lose sight of the fact that you can come to us even sooner, and we can help you throughout the entire process. And these collaborations are really critical, even more so today than 5-10 years ago, because more and more reviewers, and that's both in grants as well as manuscripts, are looking for co-collaborators that are statisticians. So unless you're submitting a grant or a journal article to a very niche specific field, almost always reviewers are going to be looking for statistical support. So it's better to involve us as soon as possible, so we can help make sure that your research is as strong as possible and increase your chances for funding and or submission acceptance of your journal, or I guess your manuscript, if I can talk. So an experienced biostatistician is competent in 4 areas. And I hope for those of you that have worked with me before that you kind of feel like this is true, and as well as with Janet and others from my group. But the 4 areas are, the first is technical and analytical. So we are familiar with modern statistical methods, software coding. So hopefully we've got some broad knowledge, and you've probably heard the terms like SAS or SPSS or R or Python. Hopefully a good statistician is knowledgeable of those softwares and the applications that you can use on those softwares to answer your research questions. The next one I would consider is a broad subject knowledge or a working knowledge of the biomedical content. Janet and myself cumulatively have about 15 years of experience working as consulting biostatisticians. So I'd hope, that we would have some experience with some data like yours or a research question like yours. And when you come and sit down with us, we can have a good conversation about, well, what's the best design for your study? How are we best defining your exposures? How are we best defining your outcomes? What type of test do we need to run to answer your research questions? So a good statistician hopefully knows a little bit about biomedical content when you come and sit down and talk with us. The next one is communication. Hopefully we are good communicators and that we have an ability to understand what you are asking of us and that you can understand what we are asking of you, and that we can work collaboratively to work out the best answers or the best solutions to your research problems and questions. And the last thing is good problem solvers. So as many of you that have worked in clinical research know, any situation just about can be multifactorial. There may be tens or even hundreds of variables that are impacting whatever relationship or phenomenon you're trying to study. A good statistician can help you with feature selection and can help you figure out how to take this really complicated situation and whittle it down to something that we as humans and researchers can understand more intuitively and really better inform our research and better inform our clinical practice. So it can, and the methods for this can be complex, right? This all kind of works together. But how do we take a really complicated problem and make it more straightforward, that where we can answer it and then we can answer it both for ourselves and then intuitively in the literature and in application. So with that said, there may be some stuff that we may not know. And I just harped on how great we are at having broad subject knowledge or broad biomedical content knowledge, but it also could be a limitation, right? So we are not physicians, we are not nurses, we are not necessarily caregivers or providers. We are technical individuals that try to take our biostat knowledge and apply it to the biomedical field. So what I mean by this is that, if you come to us and speak in acronyms or jargon or start speaking of instruments that, maybe in your field, but it's not widely known outside of your field, we may not know exactly what we're talking about. So if it's the first time that you're working with a biostatistician, I would say, act like we don't know much. And I often say that in my conference calls with people, pretend like I don't know anything about this study and let's start there and build out. And that's usually a good way to be a catalyst towards having a productive conversation towards, getting towards both of us understanding the research question. So keep it simple, especially if it's the first time you're working with us. The second thing is we are generally not database experts. This has gotten better over time, but historically people will come to us and be like, can you build our databases? Can you manage our data? Those jobs are really more data analyst focused and or database manager focused. And that's not quite the same as a biostatistician. We typically are more experts at analyzing the data, not so much cleaning it or not so much managing it. We do clean it, and we'll get to all that shortly in this presentation. But don't come to us preferably and ask us like, oh, can you help me with this really sophisticated SQL database and figure out how I need to do X, Y, and Z with that? We need to refer you to a database expert for that. With that said, we do see quite a few databases, obviously, in our work, and we can advise pretty commonly. We can advise on RedCaps, Excels, and some basic SQL databases. But if you're working with a complex registry that's exists out in California and they're doing some fancy SQL stuff out there, and you need our help, working with that, we may not be the right people to go to. But with that said, we can help send you to the right folks. So we won't ever turn you away or shun you. but just be conscious that we are more working on the analysis side than the database management side. And the last thing is something we may not know is if you work in like a super niche or a super specific field, and like only your field does this really esoteric method, we may not have the knowledge of what that method is. I kind of think of our group as like we are generalists. We are classically trained biostatisticians, and we are experts in our field. But if you come to us with like, some nuanced multi-level nonlinear regression situation that only 2 papers have ever published on, we may not exactly know how to do that. I will say that we are pretty smart folks, and we typically do figure out, the methods as we go. So with that being said, come to us earlier. The earlier you come to us, the more time it gives us to kind of figure out whatever methods you're wanting to work with. And if you can provide papers on that method or any tables or figure mockups, we can usually back our way into the analysis or the solution. But the more lead time you give us, the better. If you come to us with like a week before a deadline and it's a super complicated analysis we've not seen before, we're probably not going to be able to help you. So the better you can help us, the better we can help you, more or less. And with that said, of 100 projects come to us, 99 times out of 100, we're able to help it. This is more of a rarity. And even when a really complicated situation comes along, we can't figure it out, we do have supports around the university as well. So we will always do our best to connect you with people that can help if we cannot help ourselves. So what is the workflow for working with the biostatistician? So the bottom half of this figure is the scientist or the researcher. The top half is a statistician. And there's 2 really important communication points. The first point's on the left side of the figure here. And the bottom you see it's a block 1 says scientific question. And that's really where the investigator is coming up with what is the question I want to ask and how do I go about answering that question. It's at that point that you can come to the statistician, and that's what that dashed line indicates. And then we can help you figure out your study design and come up with a statistical plan to address your scientific question. And this is your block 2. I assume everybody can see my mouse here. And then in between block 2 and block 3 is where we kind of do the heavy lifting. It can be, some folks like to call it magic, some people like to call it analysis, whatever it may be to actually answer your research question. And then once we do that, we write up the results, or we do whatever we need to do. If it's a grant, we write up the methods for the grant. If it's a manuscript, we write the results for the manuscript. And then we communicate it back to you. And that's the next contact point right here. So these are the 2 points of most important contact with the statistician, is at the beginning and then after we're delivering results back to you. In reality, there should be another dash line in between box 2 and 3, because almost always people will give us data or give us ideas about their study design, but it's rare due to different nuances and complexities that I'm able to walk away and just do everything in one fell swoop without getting your feedback. So many times there's an additional point of contact in between box 2 and box 3 here, where maybe we get clarity on some data, or maybe we have to work through some more questions around your hypothesis or whatever it may be. So really expect at least 2 to 3 communications with us when working with the statistician to ensure that we are answering your question most directly and in a straightforward way. Also, let me know if I'm speaking fast. I've been told a few times I like to speak fast, so slow me down if I need to. All right, so with that being said, kind of giving you an idea of the workflow of working with a statistician, I've created this statistical considerations checklist. And hopefully this will kind of help answer maybe some of your questions about working with us, as well as give you an idea of the proper steps for doing a good research project. So as I've said about 5 times now, and we'll continue to say in this presentation, come to us early in your study process. The earlier you come to us, the more we can help you. So this is meant to be a little bit interactive here, this slide at least. So I guess I've given away the answer, but when do you want to contact your statistician? Would you do it A, B, C, D, E, or F? What do we think? Anybody can shout out an answer here.
A.
Yes. All right. Good. Yeah. Hopefully, yes. If you heard anything that I said, A is correct. That is during the study conceptualization phase of your study design. And really, I've arranged these in a descending order to where each step below that is getting progressively worse, and that we can help you less as we go. So if you come to us when the study is being conceptualized but needs polishing, that's fine. Honestly, we can handle that. We can still figure out any eccentricities in your hypotheses or your variables and still work out the best design and analysis plan for you. If you come to us during the data collection phase, you've kind of already at this point baked in some of your design components. Now, it's possible if you come to us before you started collecting any data, that's okay. And we can still maybe tweak it in places to make sure it's answering your research question. But if you come to us after your data is collected, at that point, like you've already done the experiment or you've already collected everything and you built in your inclusion criteria, your sample, all of these decisions have already been made without any statistician's input, and you just need analysis help. Well, it kind of handcuffs us with respect to like what kind of analysis we can actually do based upon the data you collected. So we don't have as much freedom at stage D as we would in stage A, B, and C. The next level is you performed your own analysis and you need us to check it. And as you can imagine, some of you may have some good stats chops and do a great job with this, but I've also over the years been doing this almost a decade, have seen lots of analyses that were flat out incorrect. And we have to go back to square one and start over. So, I always encourage physicians and providers and nurses and whomever to be deeply involved in their data and to run their own analyses if they want to. I love to see that because that shows that you have a lot of interest and that you want it done well and right. But come to us earlier so we can at least maybe advise and guide or even check your work as you go. And our group does offer that. I have that happen. So I have a couple very skilled physicians I work with that also know some stats, and they like to run their own analyses. But I work with them throughout the entire process, check their code, et cetera. And that way we know when we get to the finish line that we did it correctly. And then the last one, which is the worst, is you submitted your manuscript, you've got some reviewer criticisms that were really harsh, and you come back to me and you're like, hey, I need help. And at this point, there's not much at all we can do because so many decisions have been made. The process has been advanced to almost to the very end. And you're kind of asking us to come in and save the day. And we have done it, but it can be hard, and what you can say about your conclusions can be quite limited. So I bring all this up to quote a famous statistician, R.A. Fisher. And if you've ever had a stats class, you've probably heard of this guy. He's the father of modern statistics. And in short, this quote simply says, if you come to us late in the study, there's not a whole lot we can do for you. In fact, all we can probably do is just tell you how the experiment went wrong, or as Dr. Fisher calls it, how the patient died. It's a post-mortem examination of your experiment and kind of what the faults in the experiment were, but we can't necessarily fix it to make it publishable. So when you get to this stage, which again, this happens a handful of times a year with our group, there's not much we can do other than just say we're sorry and that we'll try again next time. So what are the advantages of involving a biostatistician early? Well, as I've said a couple of times now, we can really help you think through the technical objectives of your research study. What are your hypotheses? What are the data that you can collect? What are the inclusion, the exclusion criteria? What is the design? Is it prospective? Is it retrospective? Is it experimental? Is it observational? Longitudinal, cross-sectional? There's so many things you can think about, and they have whole courses on this stuff at the Rollins School of Public Health if you're interested. And what we can do from there is figure out, given the data you have, what kind of questions can you answer? What type of research hypotheses can you answer? So if you come to us sooner, we can help you think through those things. And as I've just alluded, there's like a whole process here behind the scenes. It's like you have your research questions. So say you're in clinic and you've observed some phenomenon, and you're like, I wonder why that is happening. Well, that's like step one. And then we go from that step one of what's my research question to what is a research hypothesis. And then we formulate that research hypothesis into a statistical hypothesis. And that's what's ultimately going to inform your analysis. And this presentation we're giving today is going to walk through each of these steps. So more to come on this. But that's the process. What's my research question? How do I turn that into a research hypothesis? How do I turn that into a statistical hypothesis? And I will use that to do my analysis and answer my research question that I started with. Something else we can do is help you identify your variable types, the directions and anticipated strengths of your relationships. All of these stat jargon words here, mediators, moderators, confounders, all these things that can really blow your experiment up if you're not thinking about them. We can help you think through that and make sure that our analysis adjusts for confounders or stratifies on moderators or accounts for mediators. We're there and to help you make sure that at the end of the day, whatever conclusions you make in your exposures and your outcomes is not terribly confounded or biased in some way based upon some other characteristics we maybe not have thought of. So we really want to be sure that we're there to help you consider all these complexities that exist out in the clinical wild, so to speak, that you are seeing in your practice. And then finally, we want to be sure that we help you think through and make sure that the data you can collect and the planned analysis are appropriate for answering your research questions. This happens all the time where an investigator will give me 4 or 5 research questions. Now I look at the data and I have no idea how to connect the data points to the questions that are being answered. So it's better. It's because what's happened is, they'll go to the EHR, get all this data, then come back and try to fit questions into the data they have. It's better to start the other direction. Start with your questions and then work towards getting your data. And we can help you ensure that the data you collect is in the direction of answering the questions you want to answer. So with that said, what are the preferred lead times? Like, when should you come to us? I've harped a lot on coming to us early. What is early? These are rough timelines that we have on our Biostats webpage. And the 2 bottom ones obviously have generally more hard deadlines. I guess the top one and the 2 bottom ones generally have hard deadlines. And scientific abstract almost always has a conference deadline you need to submit to. Intramural and extramural grants almost always have deadlines unless they're rolling for submission. So those deadlines are kind of baked in with respect to we have to get this deliverable finished. The manuscript can drag on a while. I would say, again, been doing this 10 years almost, an average manuscript from the first time we speak through acceptance in a journal can take a year or more. So when we say at least 1 month for manuscript preparation, that's really, in reality, a good first pass on your analysis. That's enough time for us to maybe help you think about the design, help you, and then it kind of depends upon the situation. If you are coming to us super early, we can help you through the design. Then maybe you go off for a couple of months and collect your data, and then you come back. And then once you have your data, maybe it takes us about a month or so to run that analysis, and then get you the result that you can go off and publish. These timelines are very squishy, just simply because the deadlines are very important. The actual deadlines, the conference deadline or a grant deadline is very important. But also, the more lead time you give us, the better. I will say in 2020, there's 9 of us in the Pediatric Biostats Core. We serviced over 400 projects last year. So if you work out the math on that, which I have not, that's tens of projects per person that each individual is managing. So the more lead time you give us, generally the better we can help you to make sure your study is done well, and then we can analyze it in an appropriate amount of time and meet your deadlines at the end of the day. So when you're thinking of us, though, at least rule of thumb, at least give us a month. A month almost always is going to be good enough to at least get you some deliverable back. With that said, if 10 people come to us and ask for help, probably 3 or 4 are going to come to us less than a month from their targeted deadline. And in the past, we've generally not shunned those people or turned them away. We've almost always done our best to help everybody we can and meet the deadlines that they ask us to meet. But I will say, as our demand has increased over time, demand for our services, and I will say our group is looking to increase by an N of 2 this year. So I'm hoping this will improve. But we can no longer guarantee that if you come to us like a week or 2 and I need this turned around by this date, that we can help you. But if you come to us at least with a month in advance or even a little bit more time, we will almost always meet that deadline. So, but these are roughly what you see. And these are also listed on our website. So please check out our website, which we will show at the end of the presentation to see more information about us. So we talked about coming to us early. We've beat that one to death. The next one is have an idea of your research question and your hypothesis. So we love to be involved as early as possible. So like the question is, when should you come to us in your research process? Well, I want to digress for a minute and talk about the research process of going from a research question to a research hypothesis. So a research question, the genesis of a research question generally starts around a question or a phenomenon you may see in clinic, or maybe you see in the literature, some gap in the literature, but you may ask yourself, why are things done this way? Or what if we did X, Y, or Z? And how would that impact patient care or patient outcomes? That's generally the genesis of a research question, is observing some problem or some gap in the literature. The next thing you typically do is conceptualize a theoretical framework. So what do I mean by that? it's kind of this broad qualitative piece where you go through and you figure out the key concepts in your research and you propose maybe relationships between these concepts. So you think about like, what are my clinical characteristics that I will measure? What are my outcomes of interest that I want to look at? What are maybe some of the associations between those two things that I want to consider? What are some of the variables that may be impacting those relationships? So folks generally will create a flow diagram or some type of chart or figure that kind of strings together all the relationships that you want to look at, and how can we whittle that down to something more straightforward that we can explain in a research paper. So theoretical framework typically starts big, and then we want to whittle it down to something that's more manageable when the analysis time comes. So now that you've done your theoretical framework step, what's next? Typically, folks will go to literature. They'll search PubMed or Medline or whatever your favorite electronic medical record, or excuse me, electronic search engine is. And I have this example here coming up. It's if you're looking at patients perhaps with cystic fibrosis, you may be considering searches such as ICS, which is inhaled corticosteroids, or CF, or Pseudomonas, or common lung infections. So the idea is that you've worked your theoretical framework out. You've thought as much as you can individually about the relationships. What is out there in the literature? How can I expand and figure out what variables did I miss? What relationships did I miss? In addition, the literature review is important because it helps you identify weaknesses or holes in the literature and how you can maybe fill the gaps there. So perhaps, you've seen all these papers in CF, but nobody has published on minority patients. Well, that'd be a great area for you to maybe build on the literature and fill in a hole there. So maybe that dictates what you do with respect to your recruitment in your sample. So this is a very important next step, is do your lit review. The next one is to identify your variables of interest. You've already kind of done this a little bit in your theoretical framework, but now you're kind of laying out, okay, what are my exposures? What are my outcomes? What are my confounds? Maybe my mediators or my moderators? What are these things? And, at any point here, really, I would say by step 3, you can come and talk to the biostatistician. We can really help you think about, especially in AIM 4 or step 4 here, what you can do to start formally laying out a research hypothesis that we can start maybe forming some tests around in terms of the statistics. So step 4 is a very important piece that I hope that you've talked to your statistician about. And then finally, after you've done all these steps, what is a well-informed research question? So I have this example here using the domain questions from above. So what is the effect of inhaled corticosteroids, ICS, on the instance of lung infections in children with CF? And you'll notice here, it's a research question. And the question is, you have an exposure. What is the exposure? Inhaled corticosteroids. What is the outcome? It's the incidence of lung infection. And then what is your population? The population is cystic fibrosis. This is a really nice research question because you have a clear exposure, a clear outcome, and a clear inclusion criteria, children with CF. All right, need to breathe for a second. Again, if anybody has any questions, feel free to ask me questions. I know I kind of hustle through, so please interrupt me if you have questions or comments. So the next step I want to think about is we've talked about now how to create a good research question. You start to observe some phenomenon and practice or in literature. You do a theoretical framework where you figure out all the different dynamics that could be going on in this relationship. You do a lit review. You identify exposures and outcomes, and now you come up with a good question. And the question we just had was, what is the effect of ICS on the instance of lung infection in kids with CF? But how do I turn that research question into a research hypothesis? The research hypothesis makes a prediction and is a more focused attempt to empirically answer the research question, right? So instead, in the previous question, we just simply asked, is there some relationship between ICS and lung infections? In the research hypothesis, you say, use of ICS will increase the instance. You're making a prediction. You're saying ICS is bad. Inhaled corticosteroids increases the instance of lung infection in children with CF. That is now your question that's turned into a hypothesis that we can start thinking about testing. And you can think of your research hypothesis as a bridge that connects theory and observation. So when you tie these two things together, like you're kind of getting more into the statistician's domain, where we can really help you flesh out what type of analysis is most appropriate to answer your question. Okay, the next thing, so now that you've done all these steps, which I know can be a lot, and we're here to support you in that, it kind of becomes more the fun stuff kind of comes in, like the logistics of the study. So is the study feasible? What's the population you want to consider? Are the data available? So feasibility, there's so many things that go into a research project that folks don't think about until they're about waist deep into it. What is the time that it's going to take for me to finish this study? That's a big one. If you were in a program and you need to graduate in 2 years, you don't want to do a 4-year study, right? It needs to be something that can be done adequately in the amount of time, given that you were trying to finish a program or finish whatever you're doing. The next one is the availability of subjects. If you're studying a super rare disease, maybe you don't want to do prospective data collection to where you're trying to find these rare patients out in the clinics. Maybe you want to go back and do some chart reviews and find patients in the charts, do an EPIC data pool, for instance, or EHR data pool. That's really important to think about. Another one is facilities and finances. Do you have the support staff, or do you have the support group, or do you have the money to do a study and to support the statistics, or to support the RCs, or to support whatever you're doing? These are all very critical things to be thinking about that go beyond just considering the research question. In addition, you need to also consider your own experience and ethical considerations. The majority of you, especially if you're new researchers, I imagine are going to be doing observational research. You're not doing a complex multi-site randomized clinical trial, right? We have to think about our own limitations and our own logistics and abilities when we're creating our studies. And that will be very important to make sure that you are successful in getting your studies done in a reasonable amount of time, and that you don't overextend yourself or make a big mistake and the study doesn't work out because of that mistake. Another thing to think about is the study population. And I've kind of hinted on this a little bit, but as statisticians, we can kind of help you think through some inclusion and exclusion criteria. We want, typically in our research, we want good homogeneous groups of people and when you have homogeneous groups of people or patients or whatever it is, you're really isolating potentially, what you can say about the relationship in your exposure and your outcomes. If you have a very heterogeneous group of patients or whatever you're studying, it makes it harder and it can muddy the waters with respect to the conclusions you want to make. Now, of course, there's all kinds. When I say homogeneous and heterogeneous, I'm really talking about clinically. I want to make sure that if I'm studying cystic fibrosis patients, that I'm not bringing in all these other patients that have these comorbidities with cystic fibrosis or that look like cystic fibrosis. I want to make sure that I have very clear study definitions. So when I make my conclusions at the end of the day, I can speak very directly about that population, and it won't be obfuscated by these different groups of patients that probably shouldn't have been in there. In addition, you have chart reviews. Or where did data come from? They come from chart reviews. Maybe they come from a larger EHR data pool working with the business intelligence team at Children's. It could be prospective recruitment. It could be registries. Maybe you partner with a registry in the Northeast and you want to use some of their data. Data can come from all kinds of places, and you can work with your mentors to figure out maybe what's the best place to pull some data for my research question. And if you are venturing out and doing your own prospective data collection, you are collecting your new organic data. How willing and how able are you to collect the data from the population you're trying to study? I work a lot in infectious disease research and HIV specifically. And historically, this population is very hard to bring into care and keep in care. So our prospective studies often suffer from high attrition. So when you're thinking about the study you want to carry out, think about how easy or how hard it's going to be to keep people in care, keep people in your study, and proactively make sure that you do all that you can to keep them in the study. And also, when you work with a statistician, we can help you plan out, like if 10% of your study is going to fall out due to anticipated attrition, how do we adjust our sample size? How do we adjust this? How do we adjust that to make sure that we are at least thinking about and accounting for the possibility that patients may be hard to keep in your study? Finally, testability. And I've said this a few times now. Can the variables needed to test your research question be reasonably gathered? Happens again all the time where folks, not all the time, but sometimes where folks come to us and they ask us research questions that do not line up with the data they've collected. So the better you can harmonize those two things, the more straightforward the analysis will be and our interpretations. With that said, I've harped a little bit about study design and kind of like the importance of study design. So I want to do a little caveat on that. And I want to start with something very basic, and it's simply, did the investigator assign the exposure? So in my previous example, the exposure was inhaled corticosteroids. And ICS is typically not randomly assigned. You wouldn't generally randomly assign some kids to ICS and some kids not, because it's probably based upon clinical judgment if they need the inhaled corticosteroid or not. So that would be a non-randomized study. And in fact, it would be something like an observational study. You're trying to see, like, prospectively, are the kids that get ICS different than the kids that did not get ICS with respect to outcomes? If, however, you did want to randomize perhaps some type of drug or therapy or treatment to some children and not randomize it to others ethically, and it's okay to do this, you have an experimental study, and that's on the right side. And experimental studies are typically your randomized clinical trials. So I kind of just said a little bit of this, but observational studies are generally epidemiological studies. They do not involve any intervention or experiment, but instead observe the natural relationships between exposures and outcomes. And the figure you see there is a case control study. You start with some healthy patients that are, we consider them controls, and then you start with some patients with disease, and those are your cases, and you look back at their medical history to determine if these risk factors are predictive or associated with having disease. And you've not done anything there. You've literally just found some patients that have disease, matched them up to some patients that do not, and you went and looked to see, like, how are they different or how are they similar? The flip side is the interventional or the experimental study. And that's where you start, and these are always prospective, right? Because you start with a group of folks, and then you randomly allocate some to treatment, and the other ones you randomly allocate to control, and you see how their outcomes look. And you'll notice the whole design here is there's a little bit of nuance. If you look at the case and the control, you're starting with the outcome, and you're looking back at the exposures. In an experimental study, you're starting with the exposure, i.e. the intervention, and you're looking forward to the outcomes. So the directionality of this is very critical, and it is really going to dictate your study design and what types of analysis and conclusions you can make. So with that said, I wanted to show what I call it's my hierarchy of scientific evidence. And this is a little triangle that shows at the very bottom, like the weakest evidence for scientific associations or causality, and the very top is the strongest evidence. And this is generally broken out with the idea that if you have a randomized controlled trial or a cohort study or a case control study, one individual study, how much does one individual study contribute to the scientific knowledge on a topic? And it kind of exists right there in the middle. And your observational studies in general, as I've indicated here, are that lower to middle half of the triangle. The experimental studies are almost at the top, right? So in a randomized controlled trial is actually the best you can do in a single study to demonstrate causality between an exposure and an outcome. The best is going to be your systematic reviews. And what that does in your meta-analyses, what those do is they pull information across multiple studies. You may have tens of studies in a systematic or meta-analysis, a systematic review or meta-analysis, and you can pool information across tens of studies and then make a large conclusion across all these different groups of patients, all these different, exposures, all these different, not exposures, all these different populations, all these different regions, et cetera, all these different phenotypes. And your strongest evidence for a relationship is found in your meta-analyses, whereas a randomized controlled trial is the best you can do in a single study. And then, as I said, it's followed by your observational studies. And something else that came up, I think, in the pre-survey about questions. So we as statisticians want to be involved in all facets when possible. So we do offer the service of providing randomization for your studies. So many times, especially if you're trying to randomize two groups and you're trying to have equal samples at the end of your randomization, we use something called permuted block design. It's not that hard, but we have software and we have code on our end to help you really facilitate your analysis or your randomization. So you don't have to worry about that as clinicians or as research coordinators or whatever your role is. We can help you to do that. So most studies, as I indicated on the previous slide, that are carried out by new researchers are generally observational studies. So if you're a new researcher, you're probably not doing a randomized controlled trial. You're almost certainly doing an observational study. And as we've said a few times now, what are the observational studies? Well, you have case control studies, you have cross-sectional studies, and you have cohort studies. And the cohort studies themselves can be retrospective or prospective. So I have this figure here that I think is pretty handy. On the left side is a randomized, well, it's an experimental study, right? So did you randomly allocate the intervention? If it's yes, it's a randomized controlled trial. If you do not randomly allocate the intervention, but you did in fact create the intervention, it's a non-randomized study. So you created the intervention, but you didn't randomize. And I've had studies where that's happened. That's more rare. And in fact, they can be pretty problematic because they kind of, analytically, they look like observational studies. So they require a lot more adjustment, a lot more confounding and bias than an RCT. And I don't have slides for this in this presentation, but randomization is a magical thing. Randomization, when you randomize people to a treatment versus a non-treatment, you're balancing out all the confounding between the groups, because in theory, the same confounds that exist in the control group should be the same confounds that exist in the intervention group. So randomization is a wonderful thing that makes analysis so much more straightforward. But the problem is you cannot ethically or financially or logistically randomize every single study, right? So how do we fix all the biases and confounds that arise in observational work? Well, we have to use often things like regression or propensity scores or whatever it may be. That's why you come to your statisticians. We can help you balance out those things. But with respect to observational work, what are the most common ones? Well, it's down here at the bottom. So on the far right, you have cross-sectional studies, and that's the exposure and the outcome are taken at the same time. It's truly just like a slice in time. What is the relationship between the exposure and the outcome? The case control study, as we said on the last couple slides, you start with the outcome and you look back at the exposures. In cohort studies, it's the other way around. You start with the exposures and you look forward to the outcomes. And the analysis and the conclusions from all 3, 4, 5 of these study designs are different. And when you come to us, we can help you figure out what analysis is most appropriate for each of these designs, and then make sure that we're answering your research questions as best as possible from that. Okay. So next slide. I think Janet will take over at this point. Janet, I think you're on mute. Moment. You should have control, and I think you're on mute. There you
Okay, am I unmuted? Can you guys hear me?
Yes.
Okay, something weird happened when I requested control. I could not see the unmute button. Okay, so Scott just finished talking about study design and study types. So now we're going to talk about the fun stuff, the data. So data collection, formatting, and layout. Did I just see it? Okay. So there's 3 main ways that our group gets the data. The first and the main way, the most preferred way, is the REDCap, which I'm sure many of you have heard of at this point. So there's 2 instances, the CHOA and Emory instance. And the reason why we prefer it is because you can build forms there, you can apply validation rules, and once we export it, the data comes out pretty clean, very formatted, so standardized. The second way that we usually get data is CHOA epic pools, so from the EHR. So these are usually retrospective studies, chart pools. There's some formats and standards to this type of data, but it's usually not as clean as REDCap. So there can be some back and forth with the PI once we get that data. The last main way we get data is just homegrown Excel sheets, or I guess any other data collection instrument that is used by the PI. This is least preferred just because it could be very, I guess there's not much standardization. So there's a lot more cleaning involved. So when there's a lot more cleaning, there's like less time for us to kind of do the analysis when it comes to like time constraints. Let me see. So in this slide, we actually have examples on what is the best way to format data. So can you guys tell us which is the best way, either the left or the right example to format this little piece of data? Let me see if I can see the chat. Probably not. Maybe Sky, you can see it. Great. Okay, so I see right. Yep. So it is the right side, and that's because if we would try to import the left side into our software I don't think it reads colors, at least not that I'm aware of. Let's see. So in this bottom example, can you guys, I mean, it looks pretty obvious, but as obvious as it is, we still get, I'm just gonna say it, the left side data. The right is obviously the most correct one because you have the doses in the correct unit, and it's pretty clean. Here's another example, again, an obvious one. So obviously the correct one is the left side where all the text is formatted in the same way. As if we did try to import this into our software, the right side would be would read each steroid row as like a different category. So there'd be some like back and forth with you guys on how to clean it. Again, another example that is very obvious right now, but we still get data in this left, like this left example here. Or in the right side, we have very clearly delineated like what we should do with the observations or what they are. So just to summarize, clean data helps us analyze the data much faster, and it's just better process for everyone. We do actually have a link here with more just suggested data guidelines for you guys. See if I click on it, if it opens up. But it's just a bit more examples that you guys can look at. So you can find this too on our Biostat Core website. Okay. So again, it's important to have clean data because we can then look at the data types and define these data types, which will later inform the analysis that we choose to do. So the primary exposure variable, that's usually a discrete variable. So an example, premature, yes or no. And these discrete groups, you want them to be independent and mutually exclusive. So we can do the stats test. We don't want overlap. You can have it continuous exposures as well, but typically it's discrete groups. So outcome variables, those are also usually discrete or continuous. And for discrete outcomes, they can be ordered or unordered. So here in this figure, ordered, that means the categorical data is usually has like an order, right? So like mild, moderate, severe, first, second, or third, whereas nominal, it's just groupings that don't have any inherent orders. So maybe like gender, male, female, for example. Numerical, we have our interval data, which is just continuous data. So negative to positive infinity. So maybe like lab values. And then take the chat thing away. We have ratio data. So this could be like rates of disease. Okay. So once we basically establish these data types, they will help us determine what stats test to use. So here we have this very handy chart that kind of drives down the idea that depending on how many exposure groups we have or how the exposure looks and also how the outcome looks, that will drive what stats test we end up using. So in the simplest terms, if we just have like, you know, a binary exposure and a binary outcome, we'll just use a chi-square test. Whereas if we have like a normal exposure, a normal continuous exposure, and a non-normal continuous outcome, so for instance, like glucose, somehow predicting length of stay, which would be non-normal, we'd have to use more complicated modeling. So like a generalized linear regression. Also, when we get into repeated measures, or like multiple visits, we have to use more complex modeling. So, and then the next point that we're talking about is statistical hypothesis and sample size. So once we do establish those data types and the test that we do, we can test the statistical hypothesis. So Scott talked before about this research hypothesis, but before let me see if I skipped anything. Yes. So before we basically talk about sample size, we need to convert that research hypothesis into a statistical hypothesis. So thinking back to our example, what is the effect of inhaled corticosteroids on the incidence of lung infections in children with CF? So we have two groups based on our primary exposure. We have the ICS exposed group and the ICS non-exposed. And so our outcome is looking at that incidence proportion of lung infections. So we need to convert this into a stats hypothesis in order for us to look at sample size, to do the sample size calculation. So we talk about it in terms of null and alternative hypothesis statements. So in this case, the null would be that we basically don't see a difference in that incidence proportion of lung infections between the two exposure groups. And the alternative is, we could have several alternative hypotheses. There's one-sided and two-sided. One-sided is that you expect basically that lung infection rate to be bigger in one exposure group versus the other, and vice versa. Whereas two-sided, you just say you expect there to be a difference, but you're not sure about the direction. And this is the most preferred way, unless for some reason you a priori establish like you expect the direction to be in one way versus the other. And Scott, I don't know if you have any other thoughts about that too, because I know, yeah, by default, two-sided is usually the preferred, right?
It is. Generally, if anybody brings to you a one-sided conclusion, and that was not planned a priori, like in a clinical trial, like a superiority or non-inferiority trial, and they just,
That's right.
if it was not that, and they bring you a one-sided test, you should be a little incredulous about that. So you should ask questions.
That's right.
Be questioning of it.
Yeah. So let's see, it's next. So now that we have that statistical hypothesis, we can talk about power, and power is the probability of correctly rejecting a null hypothesis when it should be rejected, when indeed there is a difference to reject. So, and the reason why statistical power is important to talk about in terms of these studies is if a study is too small, if you don't have enough patients, you will not be able to answer the research question, and you'll waste time, resources, and money, which is the worst case. Just realized we have 5 minutes left. So if a study is too large, the research question may be answerable, but you will still waste valuable time and resources, which is better but not ideal. So depending on study design, most grants should have some discussion of power. And when you come to us, when you come to a statistician, it is helpful to have a couple of this information in order for us to actually do the sample size calculation. So you want your stats hypothesis, an idea of the direction of the association that you're looking at, rough estimates of means, proportions, or variances for the outcome you're trying to study. So an effect size, in other words, and the breakdown of your exposure groups. So are they divvied out 50-50, or did you get more people to have the treatment versus not? And then some idea of how many subjects you can realistically consent. So in our example, the alternative hypothesis was that we expect there to be a difference, or that the ICS exposed group would have a higher number of lung infections. So here we see the 35% versus 25%. And then we also are provided the exposure group breakdown. So we have 40% that were exposed versus 60% unexposed. So now we can answer that question, what sample size do I need to detect that difference? And we get those numbers there. Okay, so finally, how you can reach us and funding considerations. You can actually just quickly Google search Emory Peds Biostat Core, and it's usually the first result, at least for me it is. You'll go to this website here. You can click on that link, and it opens up a biostat request form, which is in a REDCap survey, and you fill in a couple of quick questions about your research, the research title, the internal deadline, and then any one of us in the team will reach out to you, and we'll arrange a meeting right now in Zoom to talk to you about your project.
Yeah, thank you. And I wanted to have a couple more slides before we get out of here. And this is looking at the core priorities. So the lifeblood of our group are extramural, intramural grants. So many of us work off of percent effort. And usually what we do is we collaborate during the grant application process, and the investigator will put on percent of our time to work on the analysis for those studies. So those often get our most most of our attention at the beginning, simply because without the grants, we would not be able to function as a core. So those are our highest priority. That after the grants, our manuscripts and abstracts are the next highest priority. And many times those also require some amount of funding, but we'll talk about that in a moment. And then finally, the lowest priority for us are unfunded short-term research projects, that are meant to be hammered out in a couple of weeks and don't have funding tied to them. So those often take a backseat. I mentioned earlier that we do service hundreds of studies a year, and we do get to everything, but the ones towards the bottom of the triangle usually have to wait a little bit longer than the ones towards the middle and top. Go to the next slide. So with that said, if you come to us, what is the funding expectation? So all new studies from pediatric investigators, you're entitled through Children's to some free support from our group. For a manuscript or abstract, you generally get 4 to 6 hours of free help from my group, from our group. And, that seems like a lot, but in reality, it's not. We've worked on hundreds of these studies over the years, thousands really. And I've never seen a manuscript go from a first meeting through publication in 4 to 6 hours of biostat help. Generally, there's so many factors depending upon the complexity of the studies, but they generally require 20, 30, 40 hours or more of biostat's help. So virtually every manuscript we work on does require some additional funding. The grants, we generally do not charge people to work on grants because that's symbiotic. It helps us, it helps you. We do theoretically say 8 to 16 hours for grant applications, but I've never charged anybody to work on a grant as long as they write in some biostat support into that grant. But thinking back to those manuscripts and those abstracts, once the subsidized period is exhausted, how do people typically pay for us? Well, if it was a grant-funded study, they pay us with their grant. If it's not grant funded, in the past, folks will go to their senior investigator or their mentor and see if the mentor has any funding for biostats, or they may go to their department chair. Some departments around the university and the department, have funding set aside for biostats help. So check with your mentors and your chair on that. And then finally, it could be other funding mechanisms. We help nurses, we help residents, we help fellows, all kinds of folks with different types of maybe you're submitting to an internal pilot study that's only for nurses. We would help you through that just like any other grant. So we want to make sure that you are as well supported financially as possible so that you can you can have time for biostats in your project. And finally, we don't want funding to ever be a deal breaker. So speak with us early, and we try to make out a plan for everybody. I don't think we've ever turned anybody away cold turkey, even if they had no money at all. We have interns in our group that can sometimes help with work, as well as we can oversee your work. If you have no money and you want to lead the analysis on your own, we can at least oversee and make sure what you're doing is correct. So we find ways to work with you, even if you do not have money. But in general, these are the ways that people pay us, through grants, departmental funds, or other funding mechanisms. And finally, we didn't want to end the presentation. Oop, is it over? Didn't want to end the presentation on a sad note about paying money, so we put this comic at the end just to lighten it up at the end. And it is 1 o'clock. So yeah, I guess for those that are able to stay, do you have any questions for us?
So feel free to unmute yourselves if you want to ask a question. We just have a lot of thank yous in the chat.
Great.
So
yeah.
I think what you can do is contact Scott or Janet if you do have any questions, or go to the website and look at the resources that are available there. And this talk will be available, and the slides will be available on the peadsresearch.org website after this ends. Thank you very much, Janet and Scott. That was great. And I think everyone got some great information from y'all. We really appreciate it.
Thank you.
Everyone have a great day.
Thanks.
Bye-bye.
Bye.